Hi everyone, it's Dr. Towfigh. Welcome to HerniaTalk Live, our weekly Q&A every Tuesday. My name is Dr. Shirin Towfigh. I am your host and hernia and laparoscopic surgery specialist. Many of you are joining me via Zoom and others via my Facebook page as a Facebook Live at Dr. Towfigh. And thank you to those of you that follow me on Twitter and Instagram at HerniaDoc. As always, by the end of this session, I will make sure you have access to the full hour of this and all previous HerniaTalk Lives episodes on my YouTube channel. So thanks for everyone who follows me on that. So I'm very excited because today's guest is Dr. Caroline Reinke. She is currently at Charlotte, North Carolina. She is an emergency surgery specialist. She's actually more than that. We'll discuss that as we get to know her better. She works out of Atrium Health, which used to be the Carolinas Institute. You can follow her at Twitter at CE Reinke. And please say hi to Dr. Reinke. Hi, how are you?
Good evening, everybody. I'm doing great. How are you?
So nice to see you. Thanks for your time, because it's it should be 7:30 right now, p.m. your time?
Yeah.
So you probably had a long day, so I do appreciate your time. So for those of you that may not know, first of all, we've interviewed several surgeons from your institution already. We are a hernia talk group. So Dr. Vedra Augustine and Dr. Todd Henneford, both from the Carolinas, are very well-respected, well-known hernia specialists and friends of mine. And they had great sessions with me, so I'm very grateful. Your role in the hospital is a little bit different. If you can just explain how you're similar, but a little bit different than your colleagues there.
Yeah, absolutely. So we have a somewhat unique situation, although the more I talk to people, it's less uncommon than I thought. But we have a group of 7 surgeons that are general surgeons. We all did a minimally invasive fellowship, so expertise in laparoscopic skills. And we cover unassigned call, so patients that come into the emergency room, as well as an elective practice. We're a group practice, so we do really share our patients in a pretty unique way. But our goal is, I sometimes say we do emergency general surgery with an MIS flair, but a little bit of everything. And that's really what makes what I do so fun.
Yeah, so I was sharing with you that when I was around your age, I was doing a similar job. It was my first job out of residency, and it was my funnest job, I would say, because I called it my box of chocolates. You just show up to work. You have no idea what you're going to inherit. It could be the sickest patients, or it could be the most interesting patient. It's whatever comes to the emergency room, you inherit. And by offering that extra minimally invasive specialty care, then you end up, I feel, doing a better job than the typical general surgeon that just takes call. Although I must say, I do not miss taking call. That is one part of my job that I did not miss, operating between the peak hours of 10 p.m. and 4 a.m. I don't know about you.
I was going to say, so then you wouldn't count my 4 a.m. case from this morning.
Yeah, I mean, it's just, it gets too much. It's like, it's a lot.
Yes, it gets harder as the years go along.
Yes.
But
yeah, I did 6 years of it.
Fun.
And my next job, I'm like, I don't want to take call. And they're like, that's okay. We don't need you to take call. We have plenty of people that I'm like, oh my God, it's like the best job ever. No call. So yeah, but as a general surgeon, it's very hard not to take call. That's kind of like saving lives is part of what we do. So that comes with, taking call, and it is what it is. So
I mean, I think one of the really fun things about that where I am is, as you mentioned, some of my colleagues who are here, we have great relationships with them because some of what we do is take the call and help care for their patients. And so really great collaboration when there's difficult cases or challenging situations. So it's an added bonus.
So I trained at UCLA, but my job was at USC. And as you know, there's a USC, UCLA, like football rivalry, but there's
Uh-huh.
also a crosstown rivalry with everything that happens in the two campuses. So it's kind of, they were like, what do we do with this girl that just came from UCLA? Because the UCLA was considered like the more like elite institution, but also we weren't taking care of like gang violence, and we had transplant patients. We didn't have people that were shot 10 million times. So going to USC was a whole different like patient population. They assumed I wouldn't be able to handle it. Of course, I was able to handle it. So within a month of like opening up chests on the ward and saving lives and doing trauma call as backup, I earned my stripes there. But there was a little bit of, can she handle it? Because USC is a totally different animal than UCLA when it comes to their emergency medical care.
Yep.
USC is very famous.
Very interesting.
Yeah, in fact, USC at the time was the training ground, believe it or not, for surgeons before they went off to, or doctors before they went off to Iraq during the war. So, I mean, that just tells you a lot about the kind of crazy stuff we saw. But I was saying that this is the first time that we've really have the opportunity to talk about hernias in the emergency setting, because everything we talk about is either elective surgery or it's like some offshoot of chronic pelvic pain and chronic abdominal pain. Whereas dealing with your part of the world, it's all acute. So it's not the doctor, I've had, 20 years of pain in my right groin, what can it be? It's like, I'm now vomiting, or I've dead intestine, or I'm very sick, or I can't walk anymore because this thing is bulging. And then they come to you. So maybe you can give us a little bit of an idea of kind of what, since you also do elective surgery, like how it's different, the type of patients you see. Because when we talk, I've had a lot of other colleagues on board, and we talk about optimization. If you're smoker, you should smoke for months before you should stop smoking for months before surgery. Or if you're obese, you should lose weight before you have surgery. But you don't have the luxury of necessarily optimizing your patients for that perfect hernia repair. So maybe give me a little flavor of the kind of patients you tend to see.
Yeah, it's a great question. And one of the things that we, all struggle with a little bit. So, there's some patients that come in with an emergency hernia that you can temporize them. So you could, reduce the hernia or solve the acute problem. And then you get into this conversation that's really interesting. And it's one I have often in clinic or in the emergency room, where I say, we solved your emergency. That brought you to the emergency room very appropriately. And, if you told me that this happens every, it used to happen every month, and now it happens every week, and now it's happening every day, then that would push me towards like, let's just do something now.
Yeah.
If you told me, I've been thinking about quitting smoking and losing weight, and this is going to make me do it. And if you just gave me, 3 to 4 weeks, doctor, I could do amazing things. And I'd be like, okay, well, let's wait 3 to 4 weeks and see if that prophecy comes true.
Yeah.
So there's the whole balancing act that happens there when you can open that opportunity.
Yeah.
But certainly there's times that I just say, like, be honest with me. And they'll be like, I've been trying to lose weight for 30 years, and this isn't going to change it. And I'm like, all right.
Yeah.
Then, if you're coming into the emergency room, you're, using resources, it's incredibly inconvenient for the patient. Then a lot of times we just say, well, we'll give it a shot, and you just know that the outcomes won't be what they could be, but we'll give it our best.
Yeah, that's definitely a side of the world that I don't see too much, because I don't take call anymore, and it's all elective, and there are patients. So part of your patients are like sick, ill. You have to emergently operate on them. Time is of the essence. There's no like discussion. But you're right. There's a fraction of patients that are there because they're struggling with their hernia, and they've probably been to me or someone else, and I told them lose weight, or stop smoking or fix your constipation or whatever. And in the meantime, they're like in pain and they can't work or whatever. And the reality is people don't sit in the emergency room for hours and hours because they have nothing better to do. There's something that is causing them to be there and need to get that care, even if it means, waiting and so on. So that's where you kind of take that into account. Well, let's start easy. Let's share some stories of the patients that are like acutely ill. Like, why they come to you? What's the situation? And how do you usually approach those patients?
Yeah, so a recent, things always come in threes. So a recent threesome we had was a patients who come in with an incarcerated ventral hernia. That means that your bowels are through the hernia and they are stuck out, and there's nothing I can do to get them back in. All the sedation, all the pushing, all the work in the world won't get it back in. And in those situations, what we're worried about is the blood supply. And often on a CAT scan, you can see signs of, either early or late ischemia. And that is a surgical emergency.
Yeah.
And so,
how many, when you say emergency, like how many hours do you have?
Yeah, so I sort of think about it the way that we think about limb ischemia. So if we think about vascular disease and your foot, we sort of say you've got 6 to 12 hours before it dies completely.
Yeah.
And so I sort of use a similar framework, but once I see a patient with that problem, we try to get them in the operating room immediately. So we had a case I did this morning, they were in the operating room asleep within an hour and a half of getting the call. And that may sound like a long time to the rest of the world, but the way things work, if you have to meet the anesthesiologist and do all the things to prep a patient for surgery, that's pretty quickly.
Yeah, that's pretty good. And then, so this is what scares most people is, I don't want to fall into that category. A lot of times we offer surgery because we want to prevent this exact situation. But then, so now you have someone who has been sick, and what are their symptoms? If you explain like what people should be careful of to watch out for that are signs of a more acute life-threatening problem that's due to a hernia.
Yeah, so for most patients, you can talk about whether or not they can push the hernia back in. So you can say, if you can lay down and relax and push it back in, and then all of a sudden you can no longer do that, that's a reason to come to the emergency room because it's stuck out, and that's when we start to worry about blood supply. There's a small subset of patients who probably have a chronically incarcerated or stuck out hernia. And so then it's less about can it go in or out, and it's more about how does it feel. So if patients describe acute pain, it starts all of a sudden, it's more severe than sort of chronic discomfort they have with the hernia. And then almost always, if there's bowel involved, they're going to have symptoms of nausea and vomiting. And the patients will describe having nausea and vomiting, and even after they stop, there's nothing left to vomit up, they're still having dry heaves because the intestines are just feeling that things are blocked and they're trying to get it out.
And the area of their hernia tends to be more tender, more red maybe, or warm to the touch, right?
Yeah, it can depend a lot on the patient and their abdominal wall thickness. So for patients who have a thin abdominal wall, we saw one today, you can start to see those overlying skin changes where it turns red, purple, and you can tell that something's going on underneath. There are some patients who have a fairly thick abdominal wall and you won't see those changes, even though that's happening underneath. There's just enough layers over top of it that's not obvious on exam.
Yeah, we actually published a paper that looked at bariatric patients. So they underwent laparoscopic bariatric surgery, and within the first 21 days, so within the first 3 weeks, if they come in with like severe abdominal pain, you have to rule out a incarcerated, maybe strangulated trocar site hernia. So from where they did the laparoscopic surgery, but their abdominal wall is so thick because they weigh 300, 400, 500 pounds that the physical exam won't show it. But if someone comes in within 3 weeks of surgery with severe abdominal pain, then you have to rule out that problem. Now, they can get hernias later on in life, but when it occurs within the first 21 days, it's always surgical because it's almost strangulated. Whereas when they get it after 21 days, usually months to years later, then it's just like a hernia. You just fix it whenever, but it's not an acute problem. But yeah, the patients that are morbidly obese, very difficult to examine. And so what kind of imaging do you tend to get on these patients, if any?
Yeah, almost always a CAT scan is going to be incredibly helpful, both because you can see the changes in the bowel if it's really compromised blood supply, but also it helps with operative planning. So you get an idea of where the defect is relative. Not sure how much you guys have talked about this, but I often describe it as a mushroom, right? You have a defect and then you have the things that come out of it. And sometimes it's hard to tell from that where the defect is, particularly if you can't reduce it. And so a lot of times that'll help with deciding where to make our incision or how to approach the hernia.
Yeah, and how often in these really sick patients, we'll get to the less sick patients later, but these really sick patients, how often do you think laparoscopy is an approach that you would take?
So there are still patients that go as an emergency with an incarcerated hernia that I will approach laparoscopically and have success. Very commonly successful in inguinal hernias. For those, recently had success with a Spigelian hernia with that. Then I think it depends, once you get, people start to have sort of a loss of domain type situation, then that's just going to be a lot less successful because you have less room in there. And you sort of mentioned this, but it depends a little bit on how sick the patient is. So if they're really sick, then they won't tolerate the laparoscopy, and they don't really have, it does usually take a little bit of extra time laparoscopically compared to open to get the bowels completely freed. And so, are they going to tolerate the insufflation, and do you have that little bit of extra time?
Right. And then how often do you think these emergency cases, the really sick ones, are from abdominal wall hernias versus groin hernias?
The sicker ones tend to be the abdominal wall, because I think that hides better. And patients may attribute some symptoms. Either they didn't know they have a hernia, or they get symptoms and they just think, oh, I've just got a GI bug, and they wait a little bit longer. I think the groin hernias are more visible, and patients aren't like, oh, I have a GI bug. They're like, oh, I have a bulge in my groin. That's hard and won't go away. And so I think they, tend to come in a little bit sooner and be less sick.
And what about age? Do they tend to be younger or older when they come in really sick? Middle-aged? Not really make a difference?
It can vary. I think age is one of the factors. So if all the other things are the same, there probably are some older patients who either are less independent, and so, have to call someone to bring them in. Or, when you get older, you get a little bit more tolerant of pain, which can make for very lovely surgical patients, but maybe, wait things out and hoping it'll get better, because it has for the last 89 years. So surely it will today as well.
Yeah, there's always the classic patient that they do in the oral boards, or kind of the questions they ask the residents on exams, which is, elderly patient, maybe senile in a nursing home, chronically constipated, very thin, comes in with a bowel obstruction, never had surgery before. And usually the answer is an obturator hernia, or sometimes a femoral hernia, but an obturator hernia that gets missed because you can't really see it on examination. And then hopefully you get that on image, so imaging helps. But yeah, hernias can be very dangerous. Fortunately, not common to have a hernia and end up in the emergency room, but it can happen. So tell me about the not so sick patients. So people that come in a lot of pain, it's hernia related. how often do you offer urgent surgery? Is it really based on their social status and like ability to be able to get care outside the emergency room, or if they've struggled with it for years, you're trying to improve their quality of life? How do you approach those patients?
I think all of those factors play a role. So one of the recent, I had a Spigelian hernia, the ED couldn't reduce. They told him he would need surgery. In the time that I got out of the operating room and got there, he and his wife had made all the plans to have surgery that day. And I reduced it. And then I said, I could do surgery today. I can schedule you for, 2 weeks from now, whatever works best for your schedule. You'll get the same surgery. And they were like, actually, we just spent the last 30 minutes rearranging life to have it today. Could we do that? And I was like, sure, sounds great.
That's lovely.
Yeah, but that person was very healthy. They didn't smoke, they didn't have diabetes. And so that was, again, I could very confidently say to them that they were going to have the same surgery that day that they would, 2 to 4 weeks later. But we do factor all of those things, into the equation. If we have someone who says, I can't tell when it's incarcerated, and I don't know until I start vomiting every time, then you're like, maybe we do it sooner rather than later. Or again, if they have what I almost call we talk about crescendo angina in heart attacks. This is like, we talk about crescendo hernia symptoms.
That's a good one. I love that term.
Where they're getting a little more severe every time, a little bit harder to push in, and you're like, we could try to do this as an outpatient, but my prediction is that you'll come back in, even if we waited 2 weeks. So let's talk about, going
That's
ahead and doing it.
That's a great term. So there's crescendo, decrescendo. It's a music term. And so, yeah, you're right. Crescendo angina is when you're like, it's getting worse and worse and worse, like the pain like escalates. We see that with people with hernias. And that's one reason for us to kind of expedite their care, right? Whereas the same type of hernia, but in someone that's not as symptomatic, maybe you can delay surgery. But I like that crescendo. That's a good adjective. So the thing that we struggle with most, and that I get called in a lot when my colleagues are operating and there's a hernia either in the way or needs to be addressed as part of the surgery. So, often it's like a liver surgery or a transplant or something where they kind of didn't think about the hernia, and then now they're done with the surgery. They're like, okay, now we have to close. Well, shoot, how do we close? Because there's a hernia here. So you must get that where you have to operate on someone, let's say a bowel obstruction, right? Let's say someone had colon surgery and they have a hernia from the colon surgery, but it was never bothering them. They didn't do anything. Now they're here with a bowel obstruction and they need surgery. How do you handle those hernias when it's not the primary problem? It's like you also have to deal with it.
Yeah, those are tricky situations. A lot of times it's a phone call to a friend just for a second opinion, even with us. But we do, try to fix it in that time if we think it's safe. And I mean, we can always, let's just be honest, you can always fix a hernia by doing a primary repair, right? I mean, yes. I just, whether or not that's a real fix or a temporary fix, yes, gets into what we know about hernias. But if the patient is, again, otherwise pretty optimized, and sometimes we'll try, a repair that's somewhat similar to what we would do in an elective situation. Yeah. And we also have those conversations, interestingly, when we have someone who we have said no to surgery, elective surgery for, and then they come in and they have to have it. If their primary risk was not, things like diabetes, smoking, and obesity, but their primary risks were cardiopulmonary, and we've sort of had to bite that bullet, then we'll say, well, let's go ahead and do like a really formal repair because this is the only anesthesia they're getting. Right. Yeah. And so it's even for patients who we've said, no to an elective hernia repair, what we do in the emergency setting will depend on whether the no was because of their cardiopulmonary issues and general anesthesia, or whether the no was because of the risk factors around the hernia repair in terms of a surgical site infection or other problem
That's a
with the
good
hernia repair
point.
itself.
Yeah, that's a really good point, because you don't want to offer them surgery that can kill them, right? Or potentially kill them, because I always say life before hernia, right? But if they're already in the operating room, then that risk has already been taken for another purpose. That's a really good point. I like that. I always say life before hernia, because sometimes I'm at talking with the residents, they run a case by me or something, and they have like a dilemma too, like, oh, we got this hernia, but then like they didn't know if they should do a component separation, tar, like all these things I teach them, right? Tar and use this mesh and that mesh, and I was like, whoa, listen, like life before hernia. So you have to kind of bring them down a notch and say, okay, they had dead bowel, they just got shot, they have about whatever the situation is that's life-threatening. You're there for the life-threatening problem. The hernia in these situations we're talking about was not the life-threatening. It's a happenstance. They happen to also have that. So save the life, deal with the dead bowel, whatever, and then the hernia we can always fix later. And I get that a lot in these people. The surgeons often call me into the operating room and, okay, what do we do with the hernia? I was like, nothing, just, nothing. And they're looking at me like, but you're a hernia surgeon. Shouldn't we be doing something fancy with this hernia? I'm like, nope. Because I don't want them to burn the bridges, because whatever they do, it's going to fail, right? It's going to fall apart. It's going to be too tight. There may be a higher risk of infection from their surgery alone. So it's going to screw up whatever repair potentially the patient really needs. So leave that virgin territory for me later to fix it and just save the life, right? So how often do you kind of face that too?
Yeah, we face that a lot, again, sort of in patients who have, I mean, even if it's not a life-threatening thing, you could talk about acute cholecystitis in someone with sort of a massive abdominal wall hernia and taking out the gallbladder.
Yes.
Or, any other, appendicitis, diverticulitis. There's a whole list of itises that happen in the abdomen in patients who may just have hernias that exist out in the world. And I think, again, it really gets to that, we 100% practice that when there's an acute infection, you don't want to burn bridges, you're making it a higher risk repair. We just let it be, and we tell patients that we're not doing it because it's not the best thing for them. Maybe they think that in 3 days they'll wish we'd repaired it, but I tell them, in 1 year, 5 years, you wish I didn't.
Yes.
Right, because then we can do something even better and have a better longer term outcome. And for us, again, the interesting situations are the ones where there's incarcerated bowel and a known hernia, but we get there before the bowel really becomes significantly ischemic, and then we're sort of like, well, the hernia was the problem.
Yeah.
And now what do we fix it? Do we not fix it? How much do we fix it?
Yeah.
So again, if it's not the cause of the problem, I think almost always the answer we give is, save that for another day.
Yeah, totally
but when
agree.
it is, we can really get into the weeds.
Yeah, I think the issue is always the really sick patient, the dead bowel or whatever. And in some of those, I'm like, even closing the abdominal wall is not a life-saving operation. Just like get rid of the dead bowel and like get out. Like it's almost what do they call that?
Damage control, is that?
Yes, thank you. Damage control
looking
surgery.
for? Yes.
For emergency surgery as opposed to trauma surgery. But yeah, it's like for groin, sometimes they're so sick. It's not common, but when they are really sick, I'm like, just plug that hole, like deal with the bowel, plug the hole with some Surgisil or something, just to temporarily prevent another bowel obstruction while the patient's recovering, and bring them back 2 or 3 days later and when they're healthy and fix the hernia. Like, you can still do that. It's okay to stage some of these patients. There's so many options. Everyone thinks like, how do I fix a hernia now? I'm like, just let it go. It's okay. come back. You want a live patient.
Yep.
You don't want like a sick patient. Because I've seen people then struggle for another 2 hours to fix a hernia in the groin, let's say. And I'm like, you forgot the purpose that you're there is not for the hernia repair, it's for the bowel, the dead bowel, right? So
yeah. I think the hernia ones, I mean, the groin ones are the most challenging in that situation because,
yeah,
like I said, sort of the abdominal wall ones, you can just put a stitch in it or just leave it open, but somehow it feels
yeah,
harder to do that in the groin.
totally agree. Okay, let's go through some questions that were submitted. Okay, here's one question, and that is emergency hernia surgery better handled by a surgeon specialized in hernia treatment or by a surgeon specialized in emergency surgery? That's a great question.
Answer is yes. And also, that's probably, you could create an 8-hour debate on that one.
Yes, I'm sure.
Yeah. So, I think that's what we love about what we do, is that we have a little bit of expertise in both of those and feel like we can really bring that together for those patients. I think it's also one of the great things that many of our surgical societies have worked to sort of promote sharing knowledge between those who consider themselves hernia specialists and those that consider themselves emergency surgeon specialists.
Yeah.
I think both at surgical, national surgical meetings and then within your local environment, having those relationships when you get into a tough case where we can call you or, we have someone that we feel comfortable having the patient follow up with if we don't feel comfortable fixing it in the moment. But it's a tough question, and I don't think that we know the answer to it. And there's so many, the range of like who's a hernia specialist and the range of who's an emergency surgeon specialist is such a wide range that there's not, there's not one option or the other. It's hard to sort of to put those directly against each other.
Yeah. So I would say at the most half of the hernia surgeons that I know also take call. And then the people that do general surgery call, it's highly variable. I mean, there are people that still do hernia surgery the way they were trained in residency like 40 years ago, or there are people that are like really enjoy hernia surgery and can do laparoscopic, robotic, open tissue, non-mesh, whatever repair they need to do, and really approach it with the importance that we all think hernia should get. So highly variable. And most importantly, when you're in an emergency setting, you usually do not have the choice of who's going to be your surgeon, right? It's whoever's on call. Yeah. It's I tell my patients, just call me and I'll come in because I don't take call anyway. So I'm happy to come in for the, infrequent time when a patient of my own ends up in the emergency room, but that's not common. I mean, it's just really the person that's on call.
Yeah, and I think to that point, again, when you have an emergency, the goal is to get through that emergency. And, how then are you going to define better? Is better your outcome in 5 days, 30 days, 10 years?
True.
And hopefully if you have an emergency surgeon specialist who solves the immediate problem and refers you to an amazing hernia surgeon, or if you have a hernia surgeon, who's taking call, that ultimately in 8 years, 5 years, the outcome would be the same, right? So,
yeah.
Hopefully we all live in a world where you get through that emergency case, and then, whether something's done at that moment or in the interval, down the road, the outcome is good for the patient either way.
Yeah, that's there's a follow-up question to what you're saying, which is, are the outcomes different when you have emergency hernia surgery than if you have an elective surgery or semi-elective or urgent surgery?
Yeah, I think over and over again, when we look at large data, that the outcomes are worse in the emergency hernia situation. One of the things that's always hard to sort out in that is, did patients have an emergency hernia because they were too sick for an elective one? And, how much does that factor into that finding?
Good point.
Yeah, and so a lot of times I talk, if I have a crystal ball and I know that your hernia is going to cause you a problem in the next 2 years and you're going to live for 2 years, then let's do it electively. But if my crystal ball said in 2 years it wasn't going to cause you a problem and something else was going to be your major life issue, then let's avoid that risk.
We had
aren't always perfect.
That goes into that little bit of the watchful waiting trial. So we had Bob Fitzgibbons as one of our guests, who's the author of the American watchful waiting trial, and his counterpart in the UK did a similar trial, but only in males 55 and older, and he had the same results, which is nothing bad happened. People did not end up in the emergency room in hordes because they didn't get their hernia operated on. But the way they interpret the data in the UK was they specifically said an X percentage of patients had strokes and heart attacks and, as they got older, and therefore were poor candidates for elective hernia surgery. Whereas if they had their surgery 5 to 10 years prior, they would have done just fine. And so they basically said, and therefore you shouldn't sit on these people that are older that have hernias. But that's kind of a weird way of analyzing the data, because the patients did well from a hernia standpoint. They just became sicker because they were older. Still doesn't mean they needed their hernia repaired. But that's kind of what you're alluding to, though, a little bit, which is now they're in your emergency room saying, about this hernia. Right?
Yeah. And it's, I counsel patients and I see patients where I recommend not doing a hernia surgery, not infrequently. And there are a percentage of those that show up, and every time that's, not what you were hoping for. But, the truth is that is rarely the way that someone, presents and needs a hernia surgery.
Yeah, fortunately. Yeah. The other question proposed is, do you generally use mesh for emergency repairs? And if so, what types of mesh are used?
Yeah, so this is another fan favorite question that you could get a group of hernia surgeons together to talk about for hours.
Yes.
And, sometimes I explain things to patients. I would say if you had 10 surgeons and they were all seeing you, I'll say 3 of them would do this, 3 of them would do this, and 4 of them would do this. I mean, I'm sort of making up the numbers, but it's a general good thought about how much we know about what the right answer is versus how much we're doing the best with the knowledge that we have. And so that those typically fall into those situations where, again, depending on that combination of what the patient's problem is, what their hernia-related risk factors are, what their anesthesia-related risk factors are, and sort of where we are in their overall trajectory of life, we make those decisions. So there are a lot of research trials, both going forward and backwards, trying to answer that question. And lots of papers published on it every year. I think we always try to give patients the best repair that we can, that's safe, and that ultimately is the final answer. And so if it's a pretty healthy patient with a pretty clean, situation in the abdomen, then sometimes we do use permanent mesh like we would in an elective case. But if things are really infected, or I'm worried that there's a high risk of an infection, I'll probably avoid that.
What's confusing is this data that's come out that's being reevaluated, and every institution has their own kind of long-term data on it, which is usually synthetic mesh is not considered appropriate in non-clean situations. So what we call contaminated or dirty. But there's data that shows even prospectively that if you pick and choose the right patient, they do just fine. And so what's your thought on using mesh in contaminated situations?
Yeah, because then you can really get into nitty gritty about like the size of the pores in the mesh.
Yes.
Because part of the question is, you know, even if you've got some bacteria living in that world that may, you know, be more of a problem because you've got something synthetic for them to live on. If you know, the thought is that if you have more spread out mesh instead of really dense mesh, that even if there was some bacteria there, you would get be able to treat it in a way that would, you know, avoid a major problem. So, you know, if it's really contaminated, I'm probably not going to take that risk. It's just not worth it.
Yeah.
You know, we can do it with that mesh at a later time, and not have to worry about that. But certainly, you know, when we start to get into those gray areas, some of that literature, you know, might push me to, you know, consider it, you know, a large pore mesh in a preperitoneal position, you know, in a situation where there is some contamination, but not too much. But the general answer would be, you know, it's just not worth the risk.
Yeah, I think dealing with mesh infection is so difficult and poses so many risks to the patient. They need at least 2 or 3 more operations just to deal with it. And so I'm very conservative about it, but you know, there's data out there. It's hard to, you know, just be strict about it when there's data by perfectly talented surgeons that say otherwise. Wow, there's a question about leech therapy. Have you ever used leech therapy?
I have not. I was trying to think if I, at some point during residency, I think I might have been in a location where that was an option available. I believe that's true. It's been a few years, but I have not personally used it.
They're asking about leech therapy for pain and inflammation and wound healing. I mean, I know they use it for like hematomas and severe edema and like flaps and stuff for plastic surgery, but you know. Okay, so the question is, if you're talking about contaminated fields and mesh use, where is this contamination coming from? Is it from prior surgery, or maybe you can explain what we mean by contaminated or dirty wound classifications and why they would be contaminated?
Yeah, that's a great question. And again, a fun semantics and taxonomy to get into.
Yes.
But a lot of the times we go into the abdomen in an emergency situation, it's because there's either infection or inflammation of some organ, right? So if you have gallbladder inflammation, then your, you know, everything there is probably got a little bit of bacteria in it that it otherwise wouldn't have. You know, appendicitis, anything with the bowel, because it's the bowel and it's not clean. And then part of the question becomes, is it some infection or inflammation that's been ongoing for 2, 4, 10 days? And in that case, you kind of think like everything's dirty everywhere. So a great example of that is diverticulitis, because it can start small and then grow to be a bigger problem. You can also think about sort of when bowel gets stuck in a hernia and it gets injured. We think that when there's a lot of pressure and maybe less blood flow, that some of the bacteria starts to go across the bowel wall. So there's a lot of different ways to get contamination, but the general concept is that either you have a hole in something where bacteria got out, or you have a compromise in an organ where the bacteria may be able to cross membranes and planes that it wasn't doing sort of in a normal situation.
Another question has to do with patients' underlying diseases. Have you had to perform emergency surgery on a patient with severe POTS? POTS is postural orthostatic tachycardia syndrome. I mean, yeah, I don't see why.
Yeah. I mean, you might have to, give some extra support in the recovery time, talk to anesthesia about some different techniques to use. But yeah, I mean, if they need surgery, then they need surgery.
Yeah, absolutely. And just need more hydration, maybe some magnesium. In fact, in a couple months, we're going to have a POTS specialist talk about POTS, because I see a lot of patients with POTS and all these other weird diseases that are associated with hernias and hernia mesh problems. So I have a special interest to learn more about it myself, and we'll get a specialist in a couple months. So excited about that one too.
That's awesome.
I know. Okay, let's go back to watchful waiting. The question is, if on watchful waiting for confirmed hernia, what are the symptoms you should look out for to avoid emergency surgery? Great question.
Yeah, and I think, sometimes the answer to that question is not what are the symptoms that can avoid an emergency surgery, but what are the symptoms that when you need an emergency surgery, you get to it sooner rather than later. So again, if you get that hernia that's stuck out and it's usually soft, but it's firm, it usually goes in, but now it won't. You have nausea and vomiting associated with it, or the skin changes. Those are all things that I would tell patients, if you know you have a hernia and we've decided either not to fix it or to try to optimize you before fixing it, in the interval you have any of those symptoms, come in sooner rather than later. And part of that is because if you have a hernia, again, and you can push it back in, you buy a lot of time and options. But the longer it's stuck out, the more it gets inflamed. And I usually create an analogy to twisting your ankle or getting a goose egg on your forehead. The longer that after that injury, the more the swelling happens.
Yeah.
And you can imagine that it's just hard to put things back where they used to be if there's all that swelling there.
Yeah, that's true. So if you break your ankle or twist your ankle or tear something on your face, get treatment early. Otherwise, you lose a lot of options. And the scar looks really ugly if it's so swollen. Talking about scars, there's a question about what are surgeons using to minimize adhesions or scar tissue from forming during or after surgery, especially emergency surgery is known to have a higher rate of adhesion formation, right?
Yeah, so, we believe that the best thing to do to avoid hernia scar formation is to use laparoscopy when available.
Yes, there you go.
So minimally invasive incision. And then there was a foray into some options that might reduce scar tissue several years ago, none of which I think have been wildly successful. And, we'll tell patients that, if I could figure out something that would prevent scars on the inside, then of course I could retire and not be a surgeon anymore, because that would be popular for everyone, everywhere. And then, again, sort of, if we're talking about scars on the outside, just in terms of the incision and how it looks, it gets back into this weighing the risk and the benefits. So, we can close those incisions in an emergency situation with lots of very pretty options that are cosmetically appealing. But again, if there's a risk of infection, then that makes it harder to manage the infection. So trying to figure out, what is the best thing we can do with the lowest risk and balance those things.
Yeah, trauma surgery is number one in terms of risk of postoperative adhesions and bowel obstructions. I think partially because you're either bleeding, so blood is very caustic and can cause scar tissue and adhesions, or there's bowel that's let's say there's a hole in it, and so you got stool in your belly, which is also highly inflammatory and causes a lot of scar tissue. And probably third is they don't really do laparoscopy with trauma surgery, whereas you all have the extra tool of applying laparoscopic surgery, or MIS, minimally invasive surgery, to urgent or emergent situations, which I think is fantastic and great. Do you use the robot for acute care problems? Just curious.
The Royal We does. So I used to use the robot when I started, and then just fell out of practice with it. But I've got a couple of new colleagues who are really committed to it, and we've sort of just changed our access to the robot. So I suspect it will be coming back. But to me, it's a tool just like any of the other tools that we have available in the operating room. And there's no reason not to use it if it makes the surgery easier and it's available and the surgeon knows how to use it.
Yeah, I just think emergency surgery is the best part of general surgery. I went to general surgery because I wanted to save lives. I initially wanted to go into ENT, but we weren't saving lives as much as we were in general surgery. And then there's just so much you can do, and there's so much opportunities to help patients, and I just found it fun. Like I said, box of chocolates. You kind of show up and whatever. I like that rush of whatever came to the door. You can kind of go in there and help treat. I do like what I currently do, which is a lot more thinking. Like I sit down and like figure out these like mystery illnesses and problems and pain and so on. I really enjoy that. And I definitely don't want to go back to the sleeplessness that I had as a general surgeon that was doing emergencies, but I did enjoy the actual like emergency surgery part of it.
Yeah, and it's fun when you have, because it does have the thinking, trying to put together all those factors.
Yes.
And it's fun when you have a variety of tools to attack it with, right? So you have options and you get to pick which option's the best one. And we're glad that you enjoy what you do now because you bring so much wonderful knowledge to all of us.
I mean, hernias are fun, right?
Yes.
Yeah.
They are.
Yeah. And funny. Fun and funny.
Yes, they can be all of the above.
I have a guy, he's so great. I met him. He was a patient of mine, but he's like a really famous like branding and marketing guy. And he's like, the word hernia, I don't know. You gotta think of a better way of branding yourself. I'm like, well, that's what I do. He's like, hernia, it's not, I don't know. There must be a better word. And now like I've known him for 9 years now. He's like, yeah, there's no other word. It has to be hernia.
I was gonna say, was he the one who came up with like the core health and the abdominal wall specialist?
He should have.
There's lots of different names now.
It's too long, I know. Now there's abdominal core health. Here's a good question. Isn't the downside of doing laparoscopic surgery the potential of risking more hernias from the trocar sites? And how bad does scar tissue have to be to go back and clean it up? And does that put you in another risk for new scar tissue? Therefore, this kind of never-ending loop.
Yeah. So, I see a lot of patients with bowel obstructions due to scar tissue. And oftentimes the question is, why don't you just go in and fix that scar tissue? And the answer is, because then you'll create new scar tissue. And I don't know if it will create in a way that's more problematic or less problematic than the scar tissue that you have. Again, if someone could solve that problem, they would be very famous. We've studied a lot about hernias at port sites, and I think I feel fairly confident in saying that, the risk of a hernia at one of our smaller port sites, we have 5 millimeter or 0.5 centimeter ports, is pretty dang low. And there's a lot of things you can do with those small ports. Oftentimes if I'm doing a hernia repair laparoscopically, I do have to put in a 12 millimeter port, and so those are ones that I close because they're big enough that you can get a hernia there. And then you can be strategic about where you put that 12 millimeter port. So there are different parts of the abdominal wall that are more susceptible to hernias, and if you put it in a place that's got some extra protection, then that risk can be pretty low. Yeah,
very, very true. And that's where your specialty as a laparoscopic specialist understands that. Whereas I feel that people that just dabble and aren't necessarily like a true specialist, they don't appreciate that little fine tuning, putting it through the rectus versus through a diastasis has a different risk of hernia formation. And I think that's what I like about laparoscopy, which I don't like about robotics, is you have much more leeway as to where you can put your trocars, and you can
Yeah.
stack your trocars or whatever you need to do to reduce the risk of hernias, and then cosmetically you can hide it in areas that are better than you can with the robot. So that's what my one peeve with the robot is positioning of the trocars.
Yeah, I mean, there's certainly some cases, I would say a lap inguinal where the positioning is pretty much the same either way. But there's a lot of other things where the flexibility of, putting ports, it can be greater with laparoscopy than with the robot.
Yeah, I agree. And my practice is so different than when it was when I was at the county hospital. So we now do 3mm pediatric trocars for my models and and my porn stars.
That's awesome. Yes,
because they can't have any scars visible.
No, yeah, we've I've seen those and we've talked about it, but for the general population, it's been we haven't got the hospital to have those for us.
Yeah, it took me we have it for the pediatric surgery. We have 2 trays, so we use it. I steal it basically. I'm like, go to the pediatric. I'm like, is anyone using this? Okay, I'm gonna use it. And then on the surgery center side, we actually just bought one, even though we don't do pediatric surgery, because there's enough of us that have these thin people or who have jobs that need to expose their abdominal wall, and you want to be able to provide them with elective surgery that doesn't give them ugly scars. Yeah. So there is that. And doesn't everyone wear crop tops now? I mean, that's the thing, right?
Back in fashion.
Oh, here's a question about that. With smaller trocars, isn't the force increase at the point of contact?
I mean, I would say generally, I think not. There is some, again, science to how you put the trocar through the abdominal wall, so that you're not putting a lot of torque on it, depending on where you're going to be working. And also a little bit of science if you've got a great trajectory to put it in at an angle so that the holes don't exactly overlap.
Yes, exactly. I love it.
But I'm not familiar with an increased force either on the abdominal wall or in the area where you're working with the smaller trocars. I could imagine a situation where if there was more friction when you were moving in and out of the trocar, that you could end up in a situation like that. But with modern technology, I don't have issues with that.
I know. What's your favorite operation when you're on call?
I hate to say it. So it used to be the morbidly obese gallbladder, because it scares a lot of other people, and I feel very confident with it. And so it's just a place where I felt like I could really help patients that other people might be uncomfortable with. I have to say, recently I've had a couple of fun cases where I got to do, a laparoscopic preperitoneal repair, and that I wasn't planning to do that day, so it was super fun. And so
you don't have to say hernia, it can be anything.
Well, we won't get too far into the weeds of mesh, but there is a particular mesh that I like, that's self-adhesive. And we somewhat recently got that available in our healthcare system.
Yeah, it's a great mesh.
And so I've enjoyed the opportunity to use that.
It's a great mesh. Okay, one last question. It'll be a fun one. So when I was at USC, like I said, we had 2 services. We had the trauma service, which it was very famous for. And then we had everything else, which we call the non-trauma service, which was what the service I was on. And as you can imagine, the one area where we overlapped, because no one wanted to take care of it, were ingested or were foreign body retrievals. So the way that we worked it out was if it was an ingested foreign body, non-trauma would take care of it. But if it wasn't, if it was stuck up there,
Yeah.
then trauma would take care of it.
Seems
Do you guys
fair.
have that
Yeah.
problem? Did you guys have that
Um,
division of labor?
you know, we would, no, we don't. So yeah, we would take care of, we actually, one of the fun things is that we have, because we have 9 hospitals in our system, different people cover different hospitals. And so we all get to experience all of the foreign objects.
Oh, nice.
Just, depending on where the patients are and what day they come in. So
Yeah,
there's a division of labor, but not that way.
we had a resident who was so lovely. He's now a vascular surgeon. And we played a prank on him. So it was like 3 o'clock in the morning. And we fake called an emergency surgery consult to him. He was on non-trauma, which means he would only be responsible for ingested foreign bodies. And we called him and said, you need to come down here. There's a rectal foreign body. And he's like, rectal foreign bodies? That's trauma. You got to call trauma for that. Like, well, we did call trauma. The patient claims he ingested it. It's now in the rectum. So, and he was such a cool little kid. He actually went down to see this patient. It was like 3 o'clock in the morning. It's completely unnecessary, like joke we played on him. But he was like, what? Trauma doesn't want to take it because they came and saw the patient. They could have taken care of it. Like, yep, but the history was it was ingested, so it's your service.
That's awesome.
Yeah.
It's important to have fun.
The 3 a.m. fun that we have. All right. Well, that's enough fun for today. Thank you so much, Caroline. That was fun. That's 1 hour.
So much.
Thank you so much. And thanks everyone for joining me. I love these hours every week on Tuesdays, HerniaTalk Live Q&A. We've been doing this for over 2 years and I'm still having fun with it. Thanks for everyone for joining me. See you all on Facebook, Instagram, Twitter at HerniaDoc. Go to my YouTube channel. Every single one of these episodes, we are over 100 right now. You can watch live, especially today's, which was a great one. Thanks, Dr. Reinke. Thank you so much. Hope to see you soon.
Thanks for the great questions, everybody.
Take care. Bye.
Bye-bye.